Well, thank you so much for that introduction, and thank you so much for having me here. It's a pleasure to speak to you all. Thank you for the organizers for putting this together and for having me in front of you. So I've been tasked with talking about MGUS and precursor conditions overall in 25 minutes, which I have always found to be a challenge because there's so much that I'd like to introduce, from some of the history to the biology. So I'll see if I can do it in 26. These are a list of my disclosures. And I'd like to just kind of start with a case to kind of anchor us, and this story might sound somewhat familiar to you all. So let's say a 75-year-old gentleman comes to hematology oncology, has some abnormal labs that were drawn by his primary care doc, kind of some usual things on this medical history, some asthma, some acid reflux, on, omeprazole, aspirin, some family history of other things, but nothing tied to what we would consider related to myeloma. And this is the mess of his labs. And what I'll cue into is this part here, that there's an elevation in the blood total protein, the serum total protein, with a normal albumin, and this is what we call a protein gap or gamma gap or globulin gap. And so he has an SPEP sent, and you all have seen SPEPs so many times, and here's an example of one here. And they find an IgG kappa M protein. We'll talk all about what those terms are in a moment. And a patient would naturally ask, well, what is that? What does this mean? And then what does this then lead to? And let's say after some time, it's decided to work this up further, and he has a PET scan, he has a bone marrow biopsy, and let's see if this works. Because you all get PET scans all the time, and everyone's curious, what is that? What does that look like? So if this plays, this will actually show you what one looks like. So to anchor you, the right is where the R is, the left is where the L is, and it goes from skull all the way down through the toes. And what this ideally does is that it helps highlight if there are lytic lesions, really anything that's biologically, metabolically active. And I'll just keep saying whatever until this completes, because it is a full body scan, and so it is thorough. Voila, you have seen now a PET scan. Now that turned out to actually be a normal PET scan. There was nothing actually that was of note on there. And let's say they undergo then also a bone marrow biopsy, and there they find that there are 5% kappa-restricted plasma cells in the bone marrow. There's some minor cytogenetic abnormalities, nothing that's deemed high risk. And so what is this? Well, as you might imagine from my talk, this is MGUS. This is monoclonal gammopathy of undetermined significance. And that's because there's the presence of this monoclonal protein, and there's no evidence of something worse than that, such as myeloma or a monoclonal gammopathy of clinical significance, as it's been called. So I introduce all of that terminology because you're naturally going to ask, well, what is all that? What does all that mean? And that's one of the first questions I usually get from patients, which is, why is it called multiple myeloma? What is that? What does it mean? So I'd like to introduce to you a little bit of just the history to make this, I think, as understandable as possible, and then we'll dive more into that with details. So why is it called multiple myeloma? Well, it's purely historical. So the first case, so for one, actually, this is not a new disease. So I don't know if anyone caught the story of, I think it was like 2 years ago, they did a CT scan of some mummies that were found in ancient Egypt. This is from the Isle of Pharaoh, and they found lesions within the vertebra that were most consistent actually with myeloma, as best as they could tell. Of course, that is going back thousands of years. So this is not a new disease, but is one that I think has more prominence nowadays because we see it more, we talk about it more, and people are doing much better with it than they would have, so many years ago. But the first documented case that we have is from the 1840s, from an English physician, Sam Solly. And the term multiple myeloma was coined by Dr. von Rostizky in the 1870s, and he described a patient who had severe fractures. On autopsy, he then found that there were these large tumors in the bone marrow. And so he described purely what he saw then anatomically. There were multiple myelomas, myelo referring to bone marrow or spine, and oma is that suffix that means tumor or mass. You've heard of carcinoma, sarcomas. Oma means tumor mass. So he was just describing what he saw, tumors in the bone marrow, so he called it multiple myeloma. He didn't know what a plasma cell was. It had not been connected to any sort of M protein. This was just a case that had been described, but that name had stuck, and that continues to be the name that we then use now. So then what does that then connect to plasma cells? Well, those were found actually in the same decade, and this was by a different European physician by the name of Waldeyer Hartz, who, again, simply described what he saw. He saw these very large white blood cells in the bone marrow. They had a lot of cytoplasm, a lot of material, and hence he called them plasma cells. And again, that name stuck. And eventually the connection was made that plasma cells are in fact the cells that when they become cancerous are the situation of multiple myeloma. So multiple myeloma is really synonymous with plasma cell cancer. In fact, it's the only known way that a plasma cell can become cancerous. So this slide here shows you what we call hematopoiesis, the process of making blood cells, to then kind of show you where does myeloma sit. So what we deal with is right here, this plasma cell, and that's closely related to this cell called the B lymphocyte or the B cell. In fact, a B lymphocyte that fully grows up, what we call terminal differentiation, becomes a plasma cell. Now, all these other blood cells that you're seeing here have a great deal of relevance for other cancers, such as lymphomas, which are also B lymphocytes, and then these cells here, and then leukemias tend to be here. But we're talking about this, with myeloma, this cell right here, the plasma cell. Now, both B lymphocytes and plasma cells have been charged in the body of making antibodies. And so when they become abnormal, they don't stop making antibodies, they make messed up ones. And that's what we detect as monoclonal proteins, monoclonal antibodies. So as I said, a plasma cell that becomes cancerous is, again, multiple myeloma. But these are normal blood cells that live with all of us under normal circumstances. They're roughly 2 to 3% of our bone marrow, and their job is, in fact, to be antibody-producing powerhouses. And as I said, when they become abnormal, they then make abnormal antibodies. And to then show you what the structure of one looks like, this is kind of the cartoon that's always shown. An antibody kind of has this classic Y-shaped structure that we draw. That's not in reality. That's just a convenient way that we have drawn it. And on the blue here, I'll switch sides, this is what we call the heavy chain, and then these red pieces are what we call the light chains. Now, you always hear us talking about light chains, right, especially because they're so easy to track. Well, that's basically what they look like. They're just small pieces of the antibody, and they happen to be great for tracking. So again, here I've shown the blue chain as being the heavy chain and the red chain as being the light chain. And what defines an IgG versus an IgA versus an IgD is the heavy chain piece, the blue part. And there's a Greek letter that gets tied to it, but that's what defines IgA, IgD, et cetera. And then the red portion, the light chain portion, is either kappa or lambda. And so when you take it all together, you have these following isotypes, which have then these structures, and then each with kappa and lambda. So you have IgG kappa, IgG lambda, IgA kappa, IgA lambda, et cetera, et cetera. So then coming back to terminology, why is it called MGUS? Why is this, why do we have so many syllables in that name? Again, it's historical. So basically what was seen is that there were people who had monoclonal proteins, but they didn't seem sick. They didn't have what we would describe now as being diagnosed with multiple myeloma. They're what we would call now MGUS, but this was renamed things differently in the past. So benign monoclonal gammopathy or essential hyperglobulinemia. I show a picture of this gentleman here because this is Jan Waldenstrom, who had coined the most famous term, which was essential hyperglobulinemia. Now, that term was not really satisfactory because some of those people who had those M proteins actually did have trouble later. And so this gentleman, Dr. Bob Kyle, who's still alive and kicking, he's at the Mayo Clinic, he's like 98, 90, something along those lines, kind of the godfather of our field, actually, in so many ways. He renamed the situation of this benign monoclonal gammopathy or essential hyperglobulinemia, again, patients who just had an M protein but were not sick, as MGUS, monoclonal gammopathy of undetermined significance, to say that we don't know what their course will be like. That's really what that term was meant to indicate. And then we owe him a lot because he is also the one who coined the term smoldering myeloma, which is also the other portion of my talk here. And smoldering myeloma was then an acknowledgement that there are some people who had too much M protein, I'll put that in quotes, or too many cells making it to just say it was MGUS. But again, they weren't sick enough, quote unquote, to say they had conventional, active, symptomatic myeloma. So he created kind of this intermediate state of smoldering myeloma. And then kind of taking a full picture view of things, how common is myeloma and where does it sort of fit in the spectrum of cancers within the US? So it's actually not that common by incidence. It's roughly number 14. This slide is a little bit old. number 14 or 15 by incidence. The top four kind of all across the world are breast cancer, prostate cancer, lung cancer, and colorectal cancer. But what we've seen in myeloma is kind of this remarkable gap within prevalence versus incidence. So the number of new cases has slowly crept up over time, but really the prevalence has really climbed, and that prevalence incidence gap is one of the markers in cancer epidemiology of success within the field, meaning these people live longer. These people do better, they live longer, and so we see more myeloma because those people are around here today to speak about it. And so this is a busy slide here than the definitions. And the details are on there, but you don't need to necessarily know all the details. I'll just give you kind of a quick two-liner about it, and then we'll talk a little bit more about some of its pieces. In short, MGUS here is the situation where you have a monoclonal protein found. That's kind of it. And then kind of on the opposite end of the spectrum here, multiple myeloma is when you have a lot of M protein found, or a lot of plasma cells that are making that M protein, and clinical misbehavior, classically what we call the CRAB features, so calcium issues, renal issues, anemia, bone lesions. And then the intermediate state here of smoldering multiple myeloma, which I'll just say smoldering disease or smoldering myeloma, is where you have too much M protein to just say it's MGUS, which Dr. Kyle defined as greater than 3 grams per deciliter in the blood, or too many plasma cells making them, which ends up being 10% or more plasma cells in the blood. Now that is capped by 59% because once you hit 60, that's actually what we consider to be active disease. But that's where some of the details and nuances come in. In general, I think the concept is more important than the exact details per se. Classically, CRAB have been the features that we've always looked at, but we still have something called the SLIMs, the myeloma-defining events that were coming about in a Mayo 2014 paper, which are harbingers of also active disease. So if you have greater than 60% plasma cells in the bone marrow, if you're involved to uninvolved free light chain, so kappa over lambda, lambda over kappa, whichever is the misbehaving one putting on top, if that ratio exceeds 100, or if you have a lesion that's seen, even if it's very, very small, 5 millimeters, on MRI. And so this is a slide to just show you those CRAB features in more detail with the SLIMs as well. So we talk about then SLIM CRAB criteria. So to be clear, MGUS should not have SLIM CRAB criteria. Smoldering myeloma should not have SLIM CRAB criteria. Those are markers of active or symptomatic or conventional multiple myeloma. So to talk a little bit more about just some subtypes and some key facts. So we often split MGUS into non-IgM MGUS, which generally refers to IgG, IgA, then IgM MGUS, and then light chain MGUS. The most common variety is IgG. It marches towards multiple myeloma at a rate of roughly 1% per year. Of course, some people are higher, some people are lower, but that's roughly said. It's roughly 3 to 5% of the population above the age of 50 that has MGUS. And to be clear, while we're speaking of plasma cells, it's not always from plasma cells, because as I told you earlier, it's B lymphocytes that also make antibodies. So in particular, when we see an IgM MGUS, we're actually more thinking of a B cell issue rather than a plasma cell issue. And that's the line then at the bottom to say that 17% of all MGUS is in fact of that IgM variety. So this is the model of progression that you've probably seen in some other patient education handbooks. MGUS on one end, smoldering in the middle, active multiple myeloma on the end there. I've taken some pictures of some real live Mavericks situations to kind of put that into context for you. Now, reality is always more complicated than the models that we construct, because this is more like what is actually out there. So to anchor you, MGUS, again, still on the benign spectrum, myeloma there, but then there's a situation of something called plasma cell leukemia way out there. Smoldering myeloma is very heterogeneous. It's, low risk is very different from high risk, so I've separated out that there. Waldenstrom's, which I won't make too much mention of, but that's the B lymphocyte issues down there. Then amyloid you have heard of, and all these other monoclonal gammopathies of clinical significance, POEM syndrome. There's a bunch of stuff out there, some of which is arcane. Don't get bogged down with details. It's just to show you that it's always more complicated than we think. So how common is MGUS? Well, I told you the quick one-liner is roughly 3 to 5% of the population above the age of 50. But this was a paper that helped establish that. So there was no great population estimate of MGUS until really this study. And this came out of the Mayo group, whose first author you can see there was, in fact, Dr. Kyle, who I've mentioned before. who basically did a population-based sampling of Olmsted County, Minnesota, where the Mayo Clinic is housed. And they found that there roughly, that from that, the 3 to 5% of the population had a monoclonal protein. They saw a higher incidence in women, in men than women, and its incidence increased with age. So the older person was, the more likely they were to have this. And you can see some of the breakdown in the table there. And that was really the best study we had until this one, which was the ISTOP-MM study, which stands for the Iceland Screens, Treats, or Prevents Multiple Myeloma, which is to date the largest population-based trial within monoclonal gammopathies. So Iceland, small country, roughly population of 400,000. And they approached patients above the age of 40 for this. And this is a study based out of the University of Iceland as part of the IMF's Black Swan Initiative. They offered participation of roughly 150,000 people, 81,000 consented, and then 75,000 gave actual samples. So this is huge. And they had a randomization component to this where they, after they found patients, they randomized them to different groups to say nothing else, standard recommendations, or a more active monitoring of their disease. And it has given us a great amount of data on MGUS overall here. And what they found on their, just one of their initial takes to look at how much MGUS is out there, that the overall prevalence was roughly 4.5% of their population above the age of 40, which is very similar to the data that I mentioned coming from the Mayo Group. And again, IgG was the most common. They found more in men than in women. The incidence increased with increasing age. Then you could see that IgM was the second most common here, and then IgA, and then they saw multiclonal spikes in less than 10% of patients. And this is just some more numbers to there, adding to the color and some details. And what I will actually make as another point here is that it continues to be a fantastic study. It does have the caveat, though, that Iceland is a pretty homogeneous population. You might know that there's a joke that, you never know if you're marrying your cousin there. I mean, don't. If anyone watches Will Ferrell movies, Eurovision has a great scene about that. But that's to say that it's not clear how well extrapolated that data can be to other populations, right? There's not a whole lot of people with African ancestry there. There's not a whole lot of Asians there. And so it is great within their cohort there, and how well we can generalize it is actually a question that remains. That being said, it is the largest and has been a great source of data overall. And then I like to then segue to then some of our homegrown studies here. So these two come under the Dana-Farber system. There's the PROMISE study and the P-Crowd study. There are a lot of different ways that we have been trying to track monoclonal gammopathies, and these are two studies that have risen to prominence. As you heard from Jenny, HealthTree also has its own real-world monitoring systems, and if you're interested, these are actually things that you could join. Which then brings me to then the racial ethnic disparities of MGUS. So it's been well known for decades that there was kind of a flavor of racial and ethnic differentiation in monoclonal gammopathies overall. And this is one study that showed that. This looked at NHANES data, which is just a really large cohort of all kinds of patient and health metrics. And there they ran SPIPs on stored samples, and they found that MGUS within, again, this NHANES system was about 2.4%. And when they looked at a racial and ethnic breakdown, they saw that there were more monoclonal gammopathies in general in blacks compared to whites, compared to, in this case, Mexican Americans. And they saw in more men than in women, and as people aged, there was more as well. And that is, in fact, what we have seen in more than a few data sets, that in general, it's more prevalent in blacks than in whites. It seems to be the least in Asians, and Hispanics are a little bit up and down that spectrum, and always more in men than in women. And age remains sort of the #1 risk factor overall. And these are just some details adding to it. So in general, myeloma, MGUS, and really all the monoclonal gammopathies are roughly twice as common in Black Americans compared to white Americans. By some data, it's about 17%, really 10 to 20, have a monoclonal gammopathy of some sort, and it progresses to myeloma at an overall rate of 1% per year, but in Blacks, it's roughly 3 times higher. So again, why that is, I certainly don't know. and whoever figures that will be very famous, but this is something that we've seen in the data on more than a few occasions. So this was then a study that looked at people within Africa to remove the African-American experience and to say, like, is there something that might be more biological behind it? And this came out of the, it was a Dana-Farber-related study looking at Black Africans within South Africa to do a direct sampling. And there they found that MGUS was in roughly 12% of patients, which is far higher than the 3 to 5% overall number that I quoted. It had similar breakdown in terms of the isotype, so IgG was seen more than IgA and IgM. But in general, they found that there seems to be a lot more monoclonal gammopathies in African samples overall. This is a different study looking at a hospital in Ghana, and there they found that looking at myeloma itself, the median age of diagnosis is 58 years, versus if you look at the median age of diagnosis in the US, it's roughly 69 years, so quite a bit of difference. And that has been seen, again, in different data sets. So there's something about the genetic makeup of people that does have some relevance here. Now, coming back to then progression, as I said, roughly MGUS goes to myeloma at a rate of 1% per year. But there are some people who are above that, some people below that, and our attempt to model that has been really fruitful. And this is a great model that you could, in fact, access with your own data. These are the Pangea models, and this came out of the Dana-Farber system and was validated in Fred Hutch, where just taking kind of standard metrics that you get from a bone marrow biopsy in the labs, you get a model of progression. And it gives you sort of 1 year, 2 year, 5 year, and 10-year estimates. And as you go further out, the gray bars, which is like 95% confidence interval, that kind of gets wide. So, you know, it's best to use kind of a 2 year, 5 year within this. And it gives you more of a personalized estimate, if you will, of a risk of progression. Of course, this is just a model, and it's been said in stats that all models are wrong. Some are useful. So there's nothing that is tied to reality per se for a given patient's experience, but this is overall a more nuanced model rather than saying just 1% per year for everyone. And so then talking about guidelines, these are constantly being discussed. There was a great New England Journal of Medicine paper that came out earlier this year talking about things. And I think a good rule of thumb is just monitoring every 6 to 12 months with blood work. If we look at some of the more specifics within monitoring, there's no great best answer of who exactly to bone marrow. This is general guidance here. So if the M protein is small, there's no suspicion that there's something else more sinister lingering. It's reasonable to defer the bone marrow biopsy, but if there is any concern, that's where we do it. And that was with this figure here in a 2018 paper on the left, and that was basically identical then with the updated version in 2025 here. Now, there is an interesting bone marrow biopsy calculator, which is actually referenced in this 2025 paper by the iStop-MM group. But I should be clear, this has not been properly validated because of, again, that homogeneity that I mentioned within the Icelandic population, but it's still a great tool, and it uses just some basic variables that you would get from your blood tests and answers the question to some degree of should you get a bone marrow biopsy or not. Really, it's saying what's the probability that there could be smoldering myeloma or something else underneath. And again, this is publicly available. You can see the URL right there. So if you're curious, you can just plug in some numbers and play with that. And then looking at risk factors for MGUS. So, you know, what do we see as being risks overall, and then how does that tie to things that we can potentially do? The main risk factors seem to still be age, sex, race, ethnicity. Those are things you can't change. But there are a lot of possible risk factors such as immunocompromising issues, inflammatory autoimmune conditions, smoking, diet, obesity, perhaps. And then it kind of comes to the question of why does this occur overall? So with those risk factors then said, so why does it happen? And the short answer is we don't really know, but we do see alterations in the immunoglobulin heavy chain gene in about half of patients. So that's on chromosome 14. So if you look at cytogenetics on myeloma, chromosome 14 comes up a lot, 414, 1416, 1420. And that's because that's where that heavy chain, remember that blue one in the figure from much earlier in the talk, comes from. And we see alterations in that in about half of cases. Again, why that is unclear, but that seems to be tied to half of all MGUS situations overall. And so then people ask, well, what can I do then to prevent progression, to stop the march of MGUS towards anything worse. And if you go back to here, well, you can't change a lot of the main risk factors, but you can always work on these possible ones. So no one ever was worse off having a healthier diet, for instance, getting to a healthier weight. And sort of those are things that I do advocate for all patients, because even if it doesn't help specifically the situation of MGUS or smoldering myeloma, you're healthier overall nonetheless. So coming back to the spectrum here, and in light of the remaining time, I'll speed up a bit. I'll talk a little bit about smoldering myeloma. So this has kind of been the black box of monoclonal gammopathies, because to study it, you need a bone marrow biopsy, versus with MGUS, you just need the blood work or the urine work. And so not everyone's getting the bone marrow. So it's been a little bit less known overall here. And here, this image is just of a black box from a plane, which I've always found funny. It's not actually black. So how common is smoldering myeloma? Data will differ, but this is one study that looked at that question. It looked at the National Cancer Database from 2003 to 2011. And basically there, in this kind of limited data set, they saw that of all comers with myeloma, roughly 14% were of smoldering disease. And that was kind of the best data that we had until the iStop-MM, which again made much more of a population-based comment on that. And there they saw remarkably that within their large sampling, smoldering myeloma was in roughly 0.53% of patients. That's roughly 1 in 200, which kind of sent some shockwaves through the field, because that's much higher than people expected overall. Now again, it's not clear how generalizable that is, because as I said, there's a homogeneity aspect of the Icelandic population, but it's probably more prevalent than we think. And we did see, again, more in men than in women, and rises with age. That's similar to MGUS. And then when we look at progression, it's been quoted that roughly 10% per year of smoldering disease marches towards active disease. But there's a great deal of variation within that as well. And of course, that is something that we would like to model. And over the years, there have been different attempts to do this. The Spanish group, the Pethema group, had a great one. There's been an earlier Mayo model. But the one that you'll now see talk about the most is this 2220 model here, which took 400 patients at Mayo. It's been externally validated, and it uses data that you get from your initial bone marrow biopsy that gives you every piece of information that you need. And it's 2220 because if you have bone marrow plasma cells greater than 20%, if you have M protein in the blood greater than 2 grams per deciliter, and if you have a light chain ratio of the guilty over the not guilty, so kappa over lambda, lambda over kappa greater than 20, all of those are high risk factors, quote unquote. And if you have 0 risk factors, you're low risk. If you have 2 to 3, you're high risk. And you can see here how well those curves separate out. So there's a version of this that includes cytogenetics, which again you get from the bone marrow biopsy, which I haven't shown here for the sake of simplicity. But if you take then 50%, so who would then need chemotherapy? That's really what it's answering. Who progresses from smoldering myeloma to active? With those people in the highest risk group, sorry, my pointer is leaving me here, it's somewhere between 12 to 24 months. 50% of those patients would progress and hence need treatment. But in the lowest risk group, again, drawing your imaginary line for 50%, you don't even really hit it at 10 years. And yet this is all smoldering disease. So it shows you how heterogeneous smoldering myeloma is, that the high-risk patients are not like the low-risk patients. And I could argue that that's partly because that definition that was originally chosen for what smoldering myeloma is, again, from Bob Kyle in the 1960s and 70s, was a little bit artificial. But you had to start somewhere, and that's just what we've stuck with here. And in fact, high-risk smoldering myeloma might be more of a transitional state from what is conventional smoldering disease towards the conventional active disease. This gives you just some numbers of the hazard ratios for progression from smoldering to active disease within that 2220 model. And I'm going to skip over this in the interest of time, and I want to just jump then to treatment, because this ends up being a question that patients ask me very frequently, and we had a big splash from last year into now about this. So the interest in treating smoldering myeloma, basically saying, who can we treat to prevent them from having issues such as renal failure, anemia, bone lesions, high calcium, has had a lot of interest, and there have been some very aggressive treatments that have been done in the past. These are two trials that I highlight here, one looking at the combination of lenalidomide and dexamethasone in smoldering disease, and the other one looking at just lenalidomide and smoldering disease. And we did see some progression-free survival benefits, meaning there was some benefit there, but overall survival was not changed, and this never really became a standard of practice. But then last year at the American Society of Hematology's meeting in December, and then the publication was earlier this year, we had the Aquila trial. And this looked at high-risk smoldering myeloma patients and gave them just daratumumab, randomized to daratumumab versus no treatment at all, conventional monitoring. And with roughly a 400-patient group, we saw that at 5 years, the progression-free survival was 63% for the daratumumab-treated group versus 41% for the active monitoring group. And there was an overall survival benefit seen. Now, that last one is a little bit controversial because if you look at the curves, that hazard ratio was like 0.98, and if it was 1, we would not consider that significant. But this has risen as actually a very bona fide option for people who have high-risk smoldering disease and are interested in treatment. And I've had a lot of conversations about this with patients. To be clear, this is not a universal standard of care at all, but this remains an option. And as is so important within the community, as you know, options are very important. And so with that, I'd like to summarize and make a few key points that there are more entities in the family of monoclonal gammopathies, as I showed you from my messy slide, than just MGUS smoldering myeloma and conventional active myeloma. Both MGUS and smoldering myeloma are more common than we previously believed in the population. Smoldering myeloma by 2220 is a very heterogeneous entity. Some patients have much higher risk overall of active disease and needing treatment, and some people are much lower. And M proteins, as I've indicated in the background here, they can be often inert, but they can be problematic, which is why we have this field. And most patients with MGUS, as a sort of a bottom line, they will actually not develop a more advanced problem. That rate of progression is low, 1% per year, again, overall. But this is something that we monitor because at the population level, that's where we see the progression. But at the individual level, 1% means that 99% are not progressing in that given year. So with that, I see my time has been up for a bit. So I'd like to just highlight our UT Southwestern Harold C. Simmons Comprehensive Cancer Center, and these are the folks that helped us create a monoclonal gammopathy precursor clinic, including our head, Dr. Anderson there. And with that, I thank you all so much for your attention.